Hi, everybody. Welcome to Texas Primary Care Consortium's monthly Monday Primary Care Talks. My name is Nishi Singhal. I'm the program officer with the consortium. The monthly Monday Primary Care Talks is dedicated to interviewing guest speakers from across Texas, covering a wide range of primary care topics. Each month, we are bringing you informative episodes as your go-to resource on all things primary care. Today, we have an exciting episode since we actually have two speakers. Our first speaker is Dr. Ryan Van Ramshorst. He is the Chief Medical Director for Medicaid and CHIP Services at the Texas Health and Human Services Commission. In this role, he serves as a lead physician for the Texas Medicaid program, which provides needed health services to over 5 million Texans. He has been in this role since February of 2019. We also have Emily Rocha, who is the Director of Clinical Innovation at Texas Health and Human Services Commission, Medicaid and CHIP Services, and Office of the Medical Director. She leads programs focused on the care of women and children, palliative care, quality improvement, and preventative care. Her background is a pediatric critical care, emergency nursing, and hospital leadership. I'm excited for us to learn more about them, to learn more about their work in Texas Medicaid, and what was really fun to hear about were their goals for advancing primary care. Let's go to the show. Let's go ahead and get started with the both of you guys telling us a little bit about yourself and how your work impacts our primary care system here in Texas.
I'll go ahead and start. And Nishi, thank you so much for having us to be part of this series. It's a pleasure for us to be here. So I'm Ryan Van Ramshorst, Chief Medical Director for Medicaid CHIP Services, and a general pediatrician by training. And I still maintain a part-time volunteer clinical practice where I live in San Antonio and where I practiced for just about a decade. And so certainly that experience of being a primary care provider informs my day-to-day work with the Health and Human Services Commission. And just kind of getting to your question of the impact of our day-to-day on primary care. Texas Medicaid is the third largest Medicaid program in the country. Right now, we're around 5 million beneficiaries, the majority of which are healthy, typically developing low-income children. But as you know, Medicaid here also covers pregnant women and children and adults with disabilities, as well as all kids and youth in foster care. And so I really see, our program is one of providing health coverage and access to individuals that qualify. And we're all about bread and butter services, as I like to say, which is prevention, primary care, screenings, immunizations, checkups. And so, those are things that we focus on in our quality initiatives, working with our managed care organizations and trying to do all we can to support providers doing the good work that they do every day. Emily?
Hi, yes, thank you, Nishi, for having us on. This is great to do interviews, and we're always happy to talk about the work that we're doing with Texas Medicaid. So we just love to connect and communicate with those who are providing care. Our main method of communication is with the managed care organizations, and we like to just see what's going on in the world. We have meetings with the leaders, both the operational leaders as well as the chief medical officers, leading physicians in those organizations, just to be able to have that two-way communication and know really what's going on from the boots on the ground. We're always looking for opportunities to improvement to make sure that our beneficiaries are getting the best care that they can. And in my role as the Director of Clinical Innovation, I like to support innovation and improving care for beneficiaries. My background is a nurse, a pediatric nurse to be specific, and I've worked in all areas of pediatric critical care as well as hospital administration. And I like to bring kind of that experience into my role here with Texas Medicaid.
Thank you. I love that you guys both have that clinical background and that you continue to work in that setting, because I think that that's probably such a great way to, to really integrate what you're learning day to day in the clinical setting, of course, in the policy sphere. So you guys touched on this, right, with how your work impacts primary care, but we always really love to hear, in people's own words, how they're really defining primary care this could even be for your own personal experience too, but in the work that you do, how do you define primary care?
I'll start. The words that come to mind for me are long-lasting relationship and trust. You know, one of the reasons why I wanted to be a pediatrician and specifically a general pediatrician was because I wanted to work with families and watch their kids grow. And as I mentioned before, having practiced for about a decade, I've been able to see kids grow up, graduate from college, do their dream job, whether that's entering the military, becoming a teacher, or going to medical school even. And so, that relationship over time that's built on trust and compassion is just so special. And again, I'd like to think that that experience informs our day-to-day work. I think when someone thinks about someone working in government administration or essentially for a large health insurance company, which Texas Medicaid basically is, we're one of the largest insurers in Texas. I think there may be a perception that we don't have that direct connection to the people that we're serving. And so again, that basis in primary care, which has really, been what I've been interested in my entire career, informs our day-to-day decisions, looking at how we support providers and their ability to do that work.
And I'll go ahead and jump in. And from my clinical experience, providing the majority of patient care in critical care and emergency settings, I can attest to how pivotal the primary care relationship is, because anyone who's in hospital care is really only caring for patients and a part of their lives for a very brief period of time. And it's really being able to send those kids back into the community to their primary care providers to get that continuity of care, and to help them continue to build that relationship with their primary care is really essential. I wish I could just say ditto, because Dr. V's answers are great. I feel like primary care is really your main point of contact to the healthcare system. If you have a problem, like, your primary care is really that person who you're reaching out to, or that office that you're reaching out to, as that initial point. The other words that come to mind are also wellness, prevention, and then that care for disease or illness whenever it's needed. And so I think those three concepts are really interwoven together into what really creates the fabric of primary care.
Yeah, I love that. And I really appreciate your guys' perspective, because my background is public health, and I started off, wanting to go to medical school, wanting to be a clinician, and sometimes still, I'm envious of what you guys are sharing, because I love that you have, again, both that clinical perspective, but also that population health perspective too. And really, I kind of saw it early on too in my career that if I want to promote public health, working within the clinical care system is actually the best way to do that, because it's also I believe, like, the the first point of engagement of engaging in your health too.
Mhm.
And so you guys have both spoke about prevention. I'm curious on, like, a current primary care challenge that you might be working on within your work, and or if you even want to answer it more in a positive way of, like, what's a goal that you guys have for 2024 to help advance primary care?
I'll start again, and then we can transition to Emily. And Emily, what I was thinking is I'll talk a little bit about our work to reduce administrative burden, and then maybe you can touch upon the quality-based work that you've been leading with the affinity groups. So Nishi, administrative burden, paperwork, is something that gets a lot of attention. I think, we're familiar with the research that shows that clinicians are spending more time doing non-direct patient care stuff than they are actually in the room or at the bedside. And that's certainly something that there's a lot of opportunity to fix. And so we continue to work very hard with our managed care organizations, of which we have over 15. We're a managed care Medicaid state where over 95% of beneficiaries are in a managed care organization or MCO, and the providers are really the ones that are interacting directly with the MCOs. And so when it comes to things like prior authorization, we're really working with our health plans to figure out, how can we make sure that we have an program integrity, make sure that we're being responsible with the taxpayer dollar, but also making sure that it's straightforward and easy for providers to get their patients what they need. And so an example of this that has been a while in the making, as most things are when it comes to health policy, especially for a program as large as ours, has to do with prior authorization for durable medical equipment, or DME. This includes things like gastrostomy supplies for a child that might need G-tube feedings, nebulizers, incontinence supplies for a child with spina bifida, any number of types of equipment. Right now in Medicaid, when a physician orders that type of a service, generally speaking, they have to renew that authorization every 6 months. And the feedback we've received from primary care providers and subspecialists has been, well, we have a group of patients that, because of their underlying condition, are going to need that equipment, that service for a long period of time, if not their whole life. And so one of the things that we've been working with our MCOs with input from providers on is making it so we can cut in half the number of times that that service has to be authorized. And so allowing the flexibility where that authorization period could be not 6 months, but 12 months. And so we still want to make sure that there's some checks and balances, so we know that that individual is seeing their ordering clinician at least once a year for that comprehensive assessment. But again, for this subset of individuals that are going to require these services on an ongoing basis, we want to see if we can remove burden. And so again, we're helping to roll this out as a flexibility for our MCOs, who will then work with providers to tailor that to the unique communities that they serve. We've talked about this in public forums before at some of our major advisory committees, and I think some of the questions we've been asked is, well, why not go beyond durable medical equipment? And that's certainly something that we have in the back of our mind, but we would like to see how this works. We always feel like in the managed care model, we're walking a tightrope where we want to create innovation and flexibility without being too prescriptive. But without being a little prescriptive, sometimes the alignment amongst our managed care organizations can become a challenge for providers. And so we're very close to getting this across the finish line and are excited to see, not just how it impacts providers, but families. We hear from families the challenges of getting paperwork authorized. I see this in my own practice. And so really interested to see how this kind of rolls out. And it's, this is one thing, but you got to start somewhere. And so we're looking forward to rolling this out. Emily?
Thanks, Dr. V. Yes, in addition to the innovation that we're kind of seeing behind the scenes, we are also very happy and thankful to have been selected by a few different learning collaboratives for participation in those learning collaboratives. And so over the past few years, Texas Medicaid has been selected to focus on work in the postpartum care space, asthma care for children, infant well child care, and a community of practice focused on immunizations. We also have a couple more that are probably underway and going forward in the future. We've just loved our experience. So what is a learning collaborative, or also known as an affinity group? This is a national project where a few state Medicaid agencies are selected to participate and really hyper focus on a certain quality metric to improve that quality metric, to learn from each other, and most importantly, to be running PDSA cycles with really rapid fire interventions to try to achieve change on a really fast basis. PDSA, for anyone who might not be familiar with the term, is the Plan, Do, Study, Act cycle. If anyone's familiar with like Lean Six Sigma concepts, it's one of those concepts that you can take an idea, take an intervention, employ that intervention, quickly look at the implications and impact that intervention had, and then modify that intervention to go on and run another PDSA cycle. And you essentially continue that process until you've really refined and honed an intervention, a process, or a program, getting the outcome and achieving the outcome that you're looking for. And so we like to monitor some of those quality metrics that are, again, specific to each of the learning collaboratives. So back to your initial question, what are some of our goals for primary care in 2024? Well, in 2023, we wrapped up the infant well child affinity group program that was hosted by CMS. And that looked at getting children aged 0 to 15 months of age back to their primary care providers for well child visits, and of course, routine immunizations for whichever immunizations were due. And a lot of children, unfortunately, were not able to visit their pediatricians and primary care providers throughout the pandemic. And so at this time, we're playing a lot of catch up and trying to get those kids back on track. And as you all know, primary care not only is giving immunizations, but it's also doing a lot of those assessments and looking to see if there's any additional services that children might need. So we really feel that that's a key component of primary care. One of the lessons learned, it was the earlier we can get kids into their well child visits, the more likely they are to continue attending those well child visits. So anything that you can do to improve the attendance rate at those infant well child visits, really the visits right after birth and the first few months all the way through to that 0 to 15, which is what the affinity group focused on, that will carry on through the toddler and school year and even into the teenage years of a child. So if you get early believers in the infant well child visits, then you've got them for their life, really.
And Nishi, if I can add a little bit to that on the affinity group concept, I know that many primary care providers, have to renew, their credentials or their certification, and as part of those maintenance efforts, sometimes they're required by their certifying body to do quality improvement work in the clinic. And so what Emily has managed to do is really create a model of doing that targeted work with our managed care organizations, working in a very collaborative manner. Ultimately, at the end of the day, the Health and Human Services Commission, we are the regulator, we are the contracting agency, and the managed care companies are our contractors. But Emily has been able to, working with others, build relationships with the quality areas of all of those managed care organizations. The MCOs are participating voluntarily. They want to do this. They can see that the needle is moving. They're sharing best practices, which is something that doesn't always happen when you have organizations that at the end of the day are competitors to one another. But again, for this purpose of, improving infant well child rates, as Emily's last project was about, everyone's trying to get on the same page and share. This worked for us. This is something that didn't work as well. And it's been really, really rewarding to see how that model has been embraced and how other states are looking to the work that Texas has done with our MCOs as really a best practice to move the needle on various quality initiatives. Again, whether it has to do with infant well child visits, early entry into prenatal care for high-risk moms. So really excited to see that work carry on.
This is amazing, and it's so exciting to hear because I think really what you guys are just sharing is how iterative this work is, and how it really takes a team. So I love too that you're able to bring together all of the MCOs, and as you said, they are competitors, but kind of build on their shared goals, right? Or their shared learnings too, because it's really just going to benefit everyone, and then eventually, what your goals are. And so, related to that, or even going back to how you both defined, primary care in your own words, the question I love to ask people is, if you had a magic wand, what's one change you would make in the primary care system in Texas? But, thinking about how to, again, further advance primary care and really high quality primary care, right? So, here at the Texas Primary Care Consortium, we, also agree that primary care, high quality primary care, really is all about a relationship of trust between the clinician and the patient. And so, what are those changes that need to be enabled or maybe furthered, right, in order to better advance that high quality primary care? So, whether it's workforce or maybe it's advancing a certain type of policy, or maybe leveraging a certain type of policy. Even payment reform too, I know has definitely come up too. So yeah, curious on really, what is that maybe one topic or category, or even one small tactical change that could occur that you believe could really advance high quality primary care?
I'll take a stab at this one. There were actually three things that came to mind, so I hope that this magic wand is not just single use. Nishi, you mentioned workforce, and just reflecting on the fact that we just don't have enough primary care clinicians. There are counties in our great state that don't have a psychiatrist, that don't have a pediatrician, and so we just have so much more work to do. And I'm very thankful that Texas has things like the Physician Education Loan Repayment Program and a similar program for behavioral health clinicians. I'm very proud of the fact that I was a scholar for the National Health Service Corps, which is a federal program that's been around since the 70s and has put tens of thousands of primary care clinicians into underserved areas. And so it's been really rewarding to see Texas kind of embrace that model. And we're always thinking of ways to support things like that from a health policy standpoint. So that's workforce being just number one. We need more talented clinicians to want to do primary care. The second thing is just around behavioral health. I think everyone is grappling with, kids and families struggling with behavioral health issues. And because there are workforce challenges with not enough child and adolescent psychiatrists or other behavioral health clinicians, we know that primary care clinicians are on the front lines of behavioral health issues. And so better equipping primary care clinicians to work with families through behavioral health issues. I think models like the CPAN model and PeriPAN, the Child Psychiatry Access Network, and Peripartum Psychiatry Access Network are really innovative, and those are designed to support primary care clinicians in doing this work. I remember my first year of residency, interacting with a teenager who had depressive symptoms, and how my attending physician at the time, the recommendation was, this child just needs to see a psychiatrist. But obviously that doesn't work. And I have days in clinic where over 50% of the kids that I see are there for a behavioral health reason. And so I think primary care has made huge strides in helping to better support, again, children and families impacted by behavioral health, but thinking about other ways to support primary care in that. And then the last thing, and without getting too far into payment reform and other types of payment models, but I know that, on my clinic template, a well child visit is 15 minutes. And I'm always running behind in clinic, usually by 45 minutes or an hour, because I don't like to rush. And again, what makes primary care special is that time that I get to spend, that really special time with that family. And so how do we collectively create or improve the system where primary care providers have as much time as they need, or at least 30 minutes to spend with the family, working through issues. And so that's an easier said than done one. All of those three things were, but I couldn't help but mention the three.
And I'll jump in, and Nishi, I'll just start off by saying I love that you asked this question, because this is really how innovation occurs. It's when you take off all of those subconscious, kind of blinders. If you have a magic wand, what would you do? This is how innovative work really gets started. And so if I had my magic wand, I agree that I hope it works more than once. But I think I would have a wish for primary care to be available whenever and however someone needed it. The Infant Well Child Affinity group that we recently wrapped up really showed us that there are numerous reasons why someone may miss or not attend a well child visit. And so if there was any way that we could get someone their primary care however and whenever they wanted it, that would be my one wish for the magic wand. My second wish for the magic wand sort of has come true to some degree. There's always improvement that could be achieved, but I think one of the silver linings of the recent pandemic was that it really pushed a lot of industries, healthcare included, to look at technology in a different way and how can we provide care via technology. And so we have seen increased uptake in these video calls, doctor on demand, any of these, really different platforms where you can access virtual healthcare. And so just looking to see how that continues to play a part in our healthcare environment will be just fun to watch. So sort of that wish has already come true, and we'll see how that continues to play out in the future.
Thank you. I totally agree with you, Emily, that it really is a great way to just kind of be in that desired state or that dream state, right? Like I think a lot of times, which is good, like our heads are kind of in our work, down in the weeds, but I think sometimes we forget to look up to say, wait a second, where are we going? Where is our compass pointed towards? So thank you both so much. This has been very, very insightful, and I'm sure our audience will have lots of questions for you, but they'll be able to contact you, of course, after this interview. And yeah, just really, really appreciate your time. Thank you for tuning in today. I'm sure you enjoyed that interview as much as I did. And like always, you can reach out to us if you have questions or feedback to our consortium's team. If you also have any recommendations for speakers for the monthly Monday interviews, we are all ears. And of course, if you have questions for our speakers today, you will be able to contact them and learn more about their work. Thank you so much. This has been Texas Primary Care Consortium's Monthly Monday Primary Care Talks.